TopMedTalk.
Well, it's the annual meeting of the American Society of Anesthesiologists, Anesthesiology 2021, and TopMedTalk is here in person, live in San Diego, and we are so excited. I'm Desiree Chappell, your host. I'm joined by my co-host, Professor Monty Mythen, Professor of Critical Care and Anesthesia at University College London. I got it right, Monty.
You nailed it.
And Editor-in-Chief of TopMedTalk.
It's about
Monty, you're here in the States. It's a miracle.
It is good. For those people who are watching all of these back-to-back, I'm sorry about us continuing to celebrate the fact that we are here at the ASA in this wonderful city, and a big shout-out to the ASA for their bravery and commitment to bringing us all together. So there we go. Thank you.
Absolutely, absolutely. And Professor Saul Aronson. Saul, it's good to see you, brother.
It's so good to be seen and to see you, and ditto. It's just crazy cool to be in public and to be able to speak to people live again.
Man, the buzz and excitement. We say it every year. We've been at ASA for years in the past, but the buzz and excitement this year, I mean, you can just feel it. It's just the
What was that thing you stole earlier? Was it a burnout buster or a burnout antidote?
A burnout antidote.
A burnout antidote.
That's exactly what this is.
Craig taught me that.
Yeah. Well, I know there are a lot of new listeners right now for TopMedTalk, and you may be viewing from wherever you are in the world. Monty, tell us a little bit about TopMedTalk, just really quickly, because I know we've been talking about it a lot. But
broadcasting arm of evidence-based perioperative medicine. EdPom is 25 years old next year. It's a free open access medical education podcast. So go in, you can find over 1,000, I think it's over 1,500 now, podcasts. The search engine is great. The content is fantastic, and it's about to get better.
That's right. And, you can always find some of our conversations that we've had at this meeting and in the last year since COVID on our live.edpom site on the on-demand content. So be sure to check that out. We do want to thank the ASA for partnering with us this year and having us here at the ASA. It's been a wonderful experience so far, and we have some great conversations throughout the rest of the day. But let's get to our next one. So we want to introduce, and it's our privilege to introduce our next guest, Dr. Jonathan Gall. Jonathan, thank you so much for joining us.
Thank you for having me. I'm very excited to join this. This is an exciting recording here. This is wonderful.
Yeah? Have you ever been on a podcast before?
You know what? We just released the podcast, the ASA Central Line podcast, which I recorded probably a few weeks ago. Just got released on the ASA's website, on the APM webpage part of it. And you can probably check that out now.
Yeah, I was going to say, we'll give a plug for that.
We should plug that, yeah.
For sure.
Did that just happen?
You've got a great podcasting voice.
You do.
Is that right?
Yeah.
Yeah, you do.
See, this is untapped potential here. We're tapping into it finally.
Very smoky.
Yeah.
Very smoky.
John, for people who are listening and watching today, tell us a little bit more about yourself.
Well, I grew up in it. No,
so you like long walks to the beach.
So I'm an associate professor of anesthesiology in the Icahn School of Medicine at Mount Sinai, which is part of the Mount Sinai Health System. In my department there, I'm our director of Governmental and Legal Affairs, and I also do some administrative stuff for the health system too on the financial side of things. So I'm our system medical director for facility revenue integrity and optimization. A lot of that deals with facility billing, coding and documentation improvement, risk adjustment, things of that sort, to try and ensure that we get capture the true clinical picture of patients when they're here inside each hospital that we have. We have 8 hospitals in our health system. And then beyond that, part of a spin-out of our department, but also kind of in that realm of practice management too, I'm now our system medical director for Offsite Ambulatory Surgery Center Anesthesia too. So we're starting to expand our ASC footprint as part of the Mount Sinai Health System, and I'm helping my chair and our health system's chief operating officer with the anesthesia services as we build those different ASCs.
You are busy.
busy.
Yeah, that's kind of just the day jobs.
Yeah, I was going to say, in addition to that, so with the ASA, you are committee on the committee on economics?
On economics, that's right, yeah. So I've been on the committee since about 2016 or 17. Been vice chair for the last 4 years, and as of Tuesday, will be now chair of the Committee on Economics for the ASA. Very excited about that.
Congratulations.
Thank you. Yeah. It comes with quite the plan for the next few years.
I'm
the
sure there
ASA
is.
Economic Strategic Plan, ASA COE, is part of like almost every part of it. So
yeah, well,
it's exciting stuff.
That is. We can talk about that here in a little bit. But today, I think we're specifically wanting to focus around advanced alternative payment models, and that's something that we've been talking about in EdPom for a very long time, and it's a reality really for everyone in anesthesia. So just tell us just a little bit about kind of these models and your experience with that.
Sure, yeah. So one of the biggest things that I've been involved with this at the ASA level has been within the Community on Economics. We have a work group for the APMs, and I've been chairing that work group for the last couple of years. And we're finally getting a lot of things come to fruition beyond all the different panel presentations we've done about them. But one of the things that we really wanted to focus on was just getting the word out to anesthesiologists that this is what APM stands for. These are the alternative payment models. There's advanced ones, there's non-advanced ones, and that all depends on how much risk you're taking with it. And then that they happen at different levels of care. So they can be for individuals with things like MIPS, merit-based incentive payment systems, or pay for performance metrics through a certain commercial payer. They can be at the episode level, as far as like bundle payments seems to be the catchphrase for that most people are aware of. And then they can be at the population level too, for like accountable care organizations or capitation payments. And so there's all those different levels of alternative payment models out there. And it's essentially any payment model that's based off of value as opposed to volume. So traditionally, anesthesiologists have been billing, and they continue to bill on the fee-for-service framework. You provide a service, you pick out the CPT codes for that service, you send that bill in, and then you get reimbursed for that. And now there's many payment models out there, like the ones I just mentioned, that are going above and beyond just that fee-for-service part. They want to get more value out of it too. They want to see better quality, they want to see reduced costs, etc.
And the CPT code?
Those are
for our global listeners?
Yeah, that may not understand that.
Current procedural terminology codes. Right. So those are basically the codes that you submit on your claims. As opposed to writing down anesthesia for laparoscopic cholecystectomy, you write the CPT code for it, the number
so it's
for
like an ICD-10 type of code, but not, if you see me.
Similar. So the ICD-10s would be the diagnoses, and the CPTs would be the procedures that you do for those diagnoses. So like I would write, gallstone pancreatitis or choledochulithiasis as the ICD-10 code that you then associate with that anesthetic code. Yeah.
So, Jonathan, with respect to the challenges that you have or the Committee of Economics has to reach out to the anesthesiology community, broad swash across the country, many zip codes, many regions, what do you do to penetrate that audience, to sort of firstly introduce to them the importance of value-based care, and then how do you monitor the penetration of value-based care within their own domains to give them that value push of alternative payment models and coding as such?
That's a great point. I sometimes think that much of the audience is probably very green when it comes to alternative payment models. They don't really know much about them yet. It wasn't on their boards. They didn't study it when they were in residency. It's not part of their continuing medical education. It's some new stuff out there. And so I try to approach the different presentations, different resources we're putting on the ASA website, thinking that most of the audience is still rather green. There's some people that know quite a bit about it, but we're going to dive into a little bit more details on certain things as we move along with the different educational research that we're going with. So the biggest one was back in 2015 when MACRA, the Medicare Access and Chip Reauthorization Act, was passed, was that was going to bring in the quality payment program that had MIPS and APMs. MIPS is that one for the individual providers, and that took quite a lift, just even in my own department, for pulling together all the data and making sure that our providers were adequately being compliant with all the different measures to get high scores on those MIPS measures. And so that was at the individual level, and we started doing some better outreach and education along those things. And then bundles started becoming a much bigger thing around that time too, and that's where the perioperative surgical home really helps out. We actually now on the ASA website have the perioperative surgical home implementation guide, which is basically for practices who haven't been doing that yet, how to try to take baby steps into reducing variations of care, providing some extra value outside of just taking care of the patient for the anesthetic services. What else can you do beyond that? Can you do some more stuff in the post-op period? Can you do some more stuff in the pre-op period? Can you show value that only an anesthesiologist or an anesthesia practice can do that's currently not being done well by the other people who are out there? Is the orthopedic surgeon falling short on certain things? Are the nurse practitioners or whoever else might be involved in the care for an episode, like a total joint? What can the anesthesiologist bring to that and help with things like length of stay, readmissions, unplanned ED visits, things like that?
And if I may, John, are people embracing that opportunity? Because we've been discussing this for a while, the extended role of different providers. Are they saying bring it on, or is it still...
Well, so it depends on your situation, right? So if you have a lot to gain from it, of course you would. So one of the things that the probably the one community that's probably been embracing it the most is the surgeons. So an orthopedic total joint surgeon, basically all that they do all day, every day, yeah, they're going to embrace it because every one of their patients that comes into the operating room, there's a potential for them to get some gain out of that. If they, hit better metrics, they get some more of the gain sharing or the save sharings with the payer on it, then they're going to win out. For an anesthesia practice, that's just one OR right now. Maybe it's 2, maybe it's 3, maybe it's 4, whatever. But it's not 100% of your ORs. And so that's why it's important to realize that total joints was basically the first surgical bundle that was out there. Now there's bariatric surgery. Now there's lumbar spine fusion. There's cardiac surgery ones. There's maternity bundles coming out there. So pretty soon, this amount of your daily case count that's going to be part of a bundled arrangement might be up to 50% before you know it within a few years. And so now it's like, wow, half my cases, I could get some sort of gain on this. And that's where you need to start positioning yourselves now, because if you wait until half of them are in there, but you haven't been at the table yet, then you're on the menu.
So speak to that a little bit. So where is anesthesiology with respect to seat at the table today? What is the risk if they're not at the seat today? And how do they, based on personal anecdotal experience, make the case that they deserve, a piece of that cake that is sufficiently reflective of their work?
So I feel like all three of those things are out there right now, right? There's some anesthesia practices that are definitely at the table, and they're ones who have been thinking ahead of time, especially those who were part of the perioperative surgical home collaboratives, the learning collaboratives they're in our third phase of that. Those are ones who got in on this early, and now we're able to be part of that conversation, that when they hit it out of the park with the total joint bundle, all of a sudden the spine surgeons get approached by Aetna, United, whatever commercial payer it might be, or even for Medicare bundles too. And now it's like, oh, the way we did this well was the anesthesia group did this and the anesthesia group did that. Why don't we bring them in here for these conversations too, so we can figure out how to pull it off for this next one. And so those that were ahead of the game are getting continued to be brought to the table. Those who aren't there yet might passively be participating in a bundle but not even really know it.
Is it a legacy of love, or is there an objective formulaic way to define, if you will, value for each and every person that contributes?
So I feel like it really is at like the group level, that it takes a village to show value in these sorts of things, especially for an anesthesia practice. That it's you're going to do some more neuraxial anesthesia, some more regional anesthesia. You're going to try better uses for preventing post-op nausea, vomiting. You're going to do some more things for multimodal energies, other things that are going to be beneficial, and then follow up, phone calls, other sorts of things to help out in the perioperative arena. One of the things we do at Mount Sinai Hospital is we actually are utilizing physician assistants to help with better documentation and care in our PACU, in our recovery room. And one of the benefits that we're getting out of that is help with the risk adjustment for all these different things. So many of these patients are very sick in the post-op period. The surgeons know it, but they're now taking care of their next case. They don't see them until the next morning. No one else is really capturing some of that the true clinical picture and the acuity that's happening in those recovery rooms. So now our anesthesia department is helping to, capture that better, help, resuscitate them better, make sure no disasters happen there, and then any other sort of diagnoses that might happen in those in that acute perioperative period, we're capturing them too, that then help with the whole risk adjustment for these bundles. And those are things that work at the hospital level too. So, total joints is a big one across most of the CMS different measures for hospitals. Complications that are associated with them, there's certain exclusion criteria for that. Capturing all that, all those different things that might happen to a patient, complications, whatever it might be, in that perioperative arena really helps to position the hospital, the bundle, the whole group in a better light when it comes to negotiating those as things go along.
Through the specific lens of Mount Sinai versus your perspective of the nation, what's the penetration of those bundles or those episodic, care delivery bundles in a value-based sort of domain versus not quite yet? How broad is that range?
It depends on how aggressive your managed care department is, especially for like a large health system then. So if they're trying to get more into it, they're obviously going to be engaging with the payers and even some employers to try and bring in that volume. Right now, if a hospital, community hospital, or a health system is seeing some leakage to some other health systems in the area, then they're going to wind up trying to come up with strategies to get that volume back over to your place too. And then they're selling that with the value, right? So come over to our hospital because we're going to provide this care at a better quality and a lower cost. And so now, as contracting with an employer, you should have your employees come here as opposed to the hospital down the street because you're going to get that from this institution. And now, as your anesthesia practice, if you know how to understand that negotiation, what things are on the table, it's going to. A bundle is going to include all these different things inside the target price, and this is how we perform better. If you can help contribute to those conversations in ways that you can show value to that with the risk adjustment, with the helping out with a regional anesthesia to reduce length of stay and do physical therapy on post-op day 0, the day of surgery, so that they get out of the hospital faster and discharged to home as opposed to a skilled nursing facility and other things like that. If you're able to have that conversation and understand that now going into it, you're going to get much more involved in it then too, as opposed to just be a passerby.
What would you recommend to the group, the anesthesiology practice that wants to get into that space, into that game? How do they make the argument that their value is, X as opposed to 0.5X or 2X?
Yeah, so that's, you need a degree in negotiations, right?
Yeah.
And even they sometimes fail. So with this, I kind of lean on the data. If you have your anesthesia information management system, your AIMS, that helps you, know the data sometimes before the other people at the table. The surgeons have a general idea of this is what's going on, but they don't realize wow, I'm one of 10 total joint surgeons here. I don't know what the other 9 people are doing. So you have all 10 of them. You know what they're what their operating times are. You can tap into what their costs are. You can, realize how their patients perform in the post-op area. How acute are they? What other sort of, complications are they having? If you can tap into that sort of stuff and show with data, it's another way of you demonstrating that a little bit better in those situations.
So, John, if I may, from in my UK perspective, I'm not going to say European, but my UK National Health Service perspective, we are so envious about the fact that we believe that you've all got all the data on all of your patients, and it's just on your phone, you pick it up and you know everything that's going on.
I just got an alert about data, yeah.
Is that real, or is it highly variable?
Ooh, it really is highly variable, right? Because, having the data is quite the lift. Many anesthesia practices out in the country, hopefully it's very few and far between still, but are still on paper records. And so now they're sending in their bills and their claims and everything on their cases from their paper records, but they may not have a full AIMS that their practice is now leaning on. Now, many practices have really transitioned over to the new age of information technology and having that sort of data. And every one of these in this exhibit hall that does an anesthesia information management system can help you provide those dashboards, that data that you might need.
Well, it sounds very complicated.
I'm sorry. I try to.
No. I mean, you've done a great job. But for those who want more, resources, what kind of resources is the ASA providing in this space?
So we've really tried to bolster a lot of those. So I already mentioned that there's a perioperative surgical home implementation guide. And so that really is kind of the nuts and bolts of how to start looking at your variations in care and how to, take advantage of, the evidence-based medicine that's out there to try and take it, have better outcomes on all these patients. We also have the Alternative Payment Models webpage. And so that's part of the ASA website. And in there, it's part of managing your practice on the ASA website. There's an APM webpage part on there, and there's quite a few different resources out there. There's that Central Line podcast I was just mentioning, where myself and Dr. Gordon Morwood, he's the chair at Temple University, we go through all the different the individual, the bundle, and the population level alternative payment models. There's a ASA monitor article out there from some of the ASA staff like Sharon Merrick and Vanessa Salcido, along with David Martin out of the Mayo Clinic in Rochester, and they go over the new landscape of these APMs. And we also have just released this month is the Apm Assessment Framework, which is really it's in PDF format. It's about 3 or 4 pages, and it kind of goes through a lot of these different questions that we're talking about right now. What are these alternative payment models structured as? What are things you need to know about your internal group practice? What are things you need to know about your hospital and their type of involvement? Other sorts of things to prep yourself for the conversations.
Yeah.
And then how to then operationalize that within your own department. Because like I was saying before, it takes a village. So you might know what to do, but you can't do it on your own. A solo practitioner is going to be finding a lot of difficulty to pull off one of these sorts of things. And so you're going to need a lot of people involved in that sort of stuff. And that Apm Assessment Framework actually comes with a calculator tool too. So if you get approached by your C-suite that we're going to go in on this lumbar fusion bundle, it's still on the backbone of it, the framework of it is still fee-for-service things. So you have the surgeon's fees, the anesthesiologist fees, any consultants. There's going to be the hospital facility fee for it, maybe physical therapy, things of that sort. They got to pull all those things together, discharges to skilled nursing facilities and everything like that, and figure out, okay, on average, our bundle price is around $40,000 or so after taking in all those fees. We're going to try and do it for $38,000. Let's contract this out with one of the payers or our employer or something like that. How are we going to get ourselves down to that $38,000 as far as our target price goes? And so when they approach you to say, what's your fee for service for this, you're going to have to look at those CPT codes. You're going to have to see, okay, in general, they're either this sick, they operate for this many hours because, the way anesthesiologists get paid, we got the base units plus time units multiplied by the conversion factor. You're going to have to figure those things out. How often do you do regional anesthesia, other things like that, other sort of things that you would have to calculate in order to engage in that conversation. And then when you're going to supply those numbers to them, hey, let me tell you about this other stuff that we can do to help you out with this, to help you achieve your goals with this bundle so that we all win together.
Yeah. Wow. Well, it sounds like you have had a ton of success and so involved in the space where you are there at Mount Sinai. What do you look forward to see in influencing, the peers in this space? What is your vision?
So I imagine, and kind of what I was tapping in before, is that at other hospitals across the country, the percentage of cases that an anesthesiologist performs is going to be rising as far as those that are billed off this alternative payment model. That it's not just going to be 1%, 2%, 3% of your cases. In fact, for some practices out there, it might already be about 20 or 40% of your cases, and you don't even know it. You're just passively participating. You need to actively participate in this, otherwise you're going to get left behind. Everyone else is going to be getting a bigger part of the revenue, and then that kind of is a budget neutral thing oftentimes. So if there's bonus payments going out for MIPS or for bundles or things like that, it's coming off the heels of those who aren't really participating in it. So if you're not at that table, like I was saying before, you're on the menu. And so practices out there really need to start thinking ahead. You can't just work, think this weekend for how I'm going to cover Monday. You're going to think about how you're going to cover 2025 too.
Yeah.
And John, I think it's also interesting, and I'd like you to comment on this, that what today is that bonus, that shared savings that is distributed by whatever formulaic metric you would create, tomorrow is going to be a penalty. Mm-hmm. Speak to that.
Yeah, so isn't that the scary part, right? So right now, when it comes to bonuses, the way they factor bonuses is based off of upside risk. So you come up with these target prices, like I was saying before. So the lumbar spinal fusion, the target price might be $40,000. Okay, we're going to try and come in below that $40,000 and hit $38,000. Well, next year, your new target price is $38,000. And so the cliche they've been saying about this is it's a race to the bottom. So now you get down on maybe like 37, 36, 35, and now I can't go below 35 anymore, especially with inflation. And so now if you go above 35, you get penalized for that. So you got to get it while the getting's good. And then there's advocacy that goes involved with this too. And as long as you negotiate well, maybe you negotiate a 5-year contract for this as opposed to just a 1-year contract. These are other things that kind of need to go into this. When it comes to CMS, Centers for Medicare and Medicaid Services, things that they're doing with their MACRA and proposed rules and things, they've really transitioned a lot more towards the penalties. So for MIPS and the individual part, quality measures and everything, they've tried to entice you by saying that the bonuses would be as much as 9% this year, but the penalties would also be 9%. Now, if everyone submits MIPS, it's a budget neutral thing. So if you could score 100% on MIPS, you're not going to get 9%, because if not enough people don't submit and get 9% penalties, you can't get a 9% bonus. And so they've had this issue over the last few years. So they advertised it. The first year was going to be 4%, next year 5%, then 7%. And the max bonuses wound up being more like 1.68, 1.84%, things like that. But still, we got those bonuses. Many anesthesiologists in this room got those bonuses because they participated in MIPS, they submitted their measures, they were very compliant, and they did really well. Those bonuses are diminishing, and now they're really trying to shift. CMS aggressively is trying to shift providers from the individual, the MIPS, over to alternative payment models instead. And they're enticing you by a guaranteed 5% bonus in the statute. So, well, that sounds enticing. I would love to start doing that sort of stuff. So our own practice, we were able to shift into our accountable care organization, which counts as an APM. So you get the guaranteed 5% bonus out of that. Those come with the downside risk, though. So downside risk means that if you come in above, you get the penalty. You don't get the bonus payments. And so it's becoming as you can tell, there's so many different variables you need to understand, and it's very complicated. It's a lot more difficult than some things that we learned in practice, but it's part of the new age.
And it speaks even volumes to the be involved today.
Yeah.
Right.
Because if you are not involved today, not only will you forfeit the opportunity for upside, you will be more likely to receive the downside.
Absolutely.
Lastly, just in our last minute or so, how has COVID affected all of these things?
At least at the governmental payer level with CMS, they really suspended a lot of the penalty stuff. And some of the bonuses wound up also being suspended too. You could give COVID hardships, so to speak, for the reporting and things like that. So it slowed a lot of things down, at least for a year or so. But come 2022, we're only a few months away from that. It's all back on board again. They're pushing all the accountable care organizations. Most of them had been upside only. Now they're making it mandatory that you have to shift into downside risk too. And so my own accountable care organizations, most of the ones that providers here are involved in, are all shifting to that downside risk model now too. And so the penalties are going to be more aggressive as they come along. So they are forcing it on us.
Gotcha. Go ahead, Saul. You have one?
Just to the COVID point, I wanted John to speak to. This is a what do you think question. Obviously, the math is the math, and the means to pay for healthcare is still a reality. What do you think? This is the what do you think part of it. Is going to be the likely consequence to the world when we recover from COVID and we have to pay, our debts.
Thanks for that one.
That's a
Wow,
big picture
Saul.
one. Hopefully it doesn't fall on the backs of anesthesiologists.
How can anesthesiology best ensure that it doesn't?
Well, we've done an amazing job trying to show our value during this whole pandemic, right? We couldn't have gone through it without our specialty at the front lines.
Great point.
And ASA has done an amazing job making sure that message has gotten out there, and we continue to echo it over and over again. And I think that's crucial. And I think, if you're talking to your C-suite, if you're talking to your legislator, if you're talking to anybody, you got to make sure to echo that once more.
It's a really good point, Jonathan. We've been on the front lines. And
Yeah, holding it down.
One last tiny thing.
Okay.
It kind of goes to everyone to a certain extent. When we're having these conversations, do you think that all clinicians, as part of their qualification, should have to do Health Economics 1.0? Because it's not clear that we do have to.
No, I think it's crucial.
Yeah.
We practice it in our residency. We've been doing practice management oriented in the business of medicine, CME and lectures and resident talks, whatever, for years now. And I continue to do them along with my chairman and many others within our department for our department. And I believe that it should be a focus. And I know ASA is making some emphasis on this as well. That anesthesiologists, other specialties, sure. If they want to get left behind, go for it. But anesthesiologists across this country really need to understand this sort of stuff.
Thank you.
Jonathan, this has been a pleasure. Thank you so much for joining us. Great conversation. Thank you for breaking it down.
I'm sorry we got so serious.
No.
So much Star Wars.
It's all good. It's all good.
It's hard to not be serious when you're talking about money.
Yeah,
I
well,
know.
Saul,
Yeah.
coming from it is. But you know what? It's good. We need to have these conversations. It's very, very important. If people want to find out more information, asahq.org.
Yep, at that webpage. I have a panel on Monday here at the ASA conference, myself with Dr. J. Misrobian, Dr. Ed Mariano, and Dr. Dave Martin. We're doing a panel on alternative payment models and how you can show value to your institution from different sorts of perspectives, whether it be a large group practice, an academic practice, or even just with the perioperative surgical home. And so you can check that out too while you're here. And that APM webpage. And the Perioperative Surgical Home Implementation Guide. All excellent resources for any anesthesiologist.
Fantastic. Thanks so much. Have a wonderful rest of your conference. Thank you for joining us on TopMedTalk. We will be back with more great content. We have a couple more the rest of the day and all day tomorrow and all day on Monday. So please do join us live.edpom.org. Thanks for watching.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.